quiz. Chapter 1 is titled Conscientious Prescribing in the 21st Century. Not so much information from that going to be on the quiz as in Chapter 2, which is more about the way drugs affect the body and the way the body affects drugs. Now, conscientious prescribing in the 21st century. So, main things I want you to think about are, why are you prescribing medicine? Is it appropriate for what you're treating? Is it even necessary? Now, once again, this is based off of perfect world scenarios, so I'm not going to say Susie Q comes to your clinic, her urinalysis shows that she may have a urinary tract infection. However, she came with complaints of a runny nose. She has no fever, no leukocytosis, and does not complain of any pyuria. What will you treat the urinary tract infection for? Well, the real answer is nothing, because she really doesn't have a urinary tract infection. Treat the sniffly nose. I'm not going to throw stuff at you like that. Don't worry about it. For Chapter 1, there are some basic things that are probably important for you to know. On page 5 is a table of DEA schedules. Just review that. Know what you can prescribe for your scope of practice. For nurse practitioners in Arkansas, of course, it's Schedule 3, 4, and 5, narcotic and non-narcotic, and now Schedule 2 hydrocodone combination products, which used to be a Schedule 3, and they simply made it a Schedule 2. And then I guess everybody got tired of having to write hydrocodone because the nurse practitioners couldn't, so it's back on the table. Just be familiar with that. I'm not going to ask you specific drugs for now. Get a medical reference. I'm sure most of you have one. Everybody talks about Hippocrates and how great that is. If you want to pay the money for it, good for you. I and some of my colleagues, we use Medscape. The app for your smartphone is free, and it's got all the information you need, especially with regard to schedules, pregnancy categories, and all that kind of stuff. So pay attention to the table on page 5. This chapter is full of a lot of historical information that's very interesting, but not necessary for the examination. That's something that you might read later on whenever you just think, well, how'd that come into place? There's some history in there. On page 11, table 1-3, 6 timeless questions to improve prescription safety and efficacy every prescriber should answer before any prescription leaves with the patient. Read through those 6 questions. Those you will see on the exam most likely, not all of them, but maybe 1 or 2 of them. And this goes over what I was explaining earlier. It's not so much the particulars, but the foundation. For example, question number 1 is, have you thought through the reason why you're prescribing a particular medicine? Are you prescribing Levaquin for the urinary tract infection I just described that doesn't actually exist? Well, think about that. The second question is, have you enough experience with any one drug to know its expected outcomes in a population of patients? That will only come with what the question itself asks, and that's experience. Don't worry. Those are things you're going to learn from your mentors, your preceptors, your collaborators. That one is something that will come with time. And it does not matter how long you've been practicing, you're going to encounter a new medicine every day. And when I say new, I mean new to you. It won't necessarily be a new product, but it will be something you're not used to prescribing or have never prescribed before. Don't think you're going to look like an idiot by asking somebody, hey, what's this about? We all do it. I've had physicians even ask me about certain medicines because they've heard me prescribe them before. Very important question, number 2, because it really has to do with safety. The third question is, are you prescribing this drug as a result of a telephone consultation or email, or have you really examined the patient? For the purpose of this class, we're going to assume we're examining all of our patients. You will get into situations in your practice, especially as family practitioners, where people want prescriptions called in and thus and such. That question is not always black and white, but perfect world scenario, yes, examine the patient. Regular world scenario, um, you may know the patient like the back of your hand. You may have been treating them all year long, and you know exactly what needs to be done. Uh, but if you were to see such a question on a quiz, the answer would be that you would want to examine the patient. The fourth question is, have you talked enough with this patient so that you're comfortable that the dosing schedule has been shared and agreed upon? That simply is a customer service sort of issue. Okay, patient, this is what I'm going to prescribe for you. This is how it works. This is when you're going to take it, and this is how long. Is that okay with you? And that last part about asking the patient's permission is not actually asking permission. It's just making sure truly that they understand what's going on, because you're in control of what's going to be prescribed. We'll talk more about that when it gets to pain medicine. Fifth question is, have you considered the long-term effects of your prescribing a particular drug when you want the patient to stop taking it? That will kind of tie into the next chapter about pharmacokinetics and pharmacodynamics. And I know you've all heard about this in undergraduate school, but some medications last in the body far longer than others. Some compete with others. Take amiodarone, for example, something you will probably see from many of your patients. We live in Arkansas. Chronic diseases reign, which keeps us all employed. Heart disease, atrial fibrillation. A lot of people on amiodarone. It has an incredibly long half-life. Same thing with some of the sulfonylurea medications for diabetes, glyburide, for example. You may see a patient who's persistently hypoglycemic, and you'll find that they're taking glyburide, and you'll put them in the hospital, and they'll be hypoglycemic for 5 days after stopping the medication. It takes that long for it to get out of your system, so to speak. Some drugs, for example, Paxil is a selective serotonin reuptake inhibitor, is something that you can start someone on newly for depression because it has a short half-life. It works more quickly. And if it's not a good choice, it can be tapered off more quickly. So, considering long-term effects, question number 5 really will come with experience and practice to be able to answer that question thoroughly for yourself and your patients. Last question on these timeless questions is, before doing anything, do you have an accurate medication history on this patient? That is probably the most important question, second to number 1. Why are you prescribing it? Number 2 is, what the heck is the patient taking already? The days of patients coming to your clinic or my hospital with 2 pages of medications has got to end. Always take that with you no matter where you go. Pay attention to patients' medications. Quiz them about them. Take 5 minutes to say, hey, are you taking this? Are you taking this? Who prescribed this? Why? 9 out of 10 times, 50% of the medications people are on, they don't know why they're on them, nor do they need to be on them. Okay. Going forward, I think that's actually all in Chapter 1. It is. So go to Chapter 2, Introduction to Pharmacokinetics and Pharmacodynamics. This is the more important introductory chapter. I keep cutting off the top of my head. I hope that doesn't bother anybody, because I know you're all trying to admire my wonderful haircut and figure out how I do this every day. So I'll try not to make it too hard for you. This chapter's got the meat and potatoes for the quiz. First thing, flip to page 21. There's simple definitions of things you need to understand. What is pharmacodynamics? What is efficacy, potency? Read through all of that. The main thing is we're talking about here is chemistry. Remember from physiology in undergraduate school, cells have receptors. Receptors are like door locks, and they allow certain keys to open them. Those keys are enzymes, certain things that bind in specific ways to make a cell do a certain thing. So, and also, this is something I think of when you're treating a patient with medicine. Don't think of that patient as a human being. I mean, you do, but imagine that patient is a single cell. Because we are just billions of single cells piled together, what you are trying to do with medicine is alter one cell. Well, a lot of the same kind of one cell. So, refresh yourself with pharmacodynamics. Basically, pages 21 through 24. There's some good information on 25.